Welcome to the first NHS Lanarkshire Leadership podcast. I'm Calvin Brown, Director of Communications for NHS Lanarkshire. The idea for this podcast started with a successful funding bid for realistic healthcare that NHS Lanarkshire made to the Scottish Government. Part of the bid was a commitment to have a virtual interactive session with staff. This is also an opportunity to celebrate and support our wonderful staff, particularly given the challenges of the COVID pandemic. One of the ways we can do this is by showing visible leadership and answering the questions that are important to you. To help answer those questions, our panel today is our Chief Executive, Heather Knox, our Medical Director, Dr. Jane Burns, and our Director of Nursing, Midwifery and Allied Health Professions, Eddie Docherty. Thank you for joining us, and thank you also to the Quality Directorate who have been speaking to staff to find out the questions they want answered. If this format and you like it, we will make this into a regular series of podcasts, so no pressure at all on our panel. We'll now get straight to the questions. First one, which I think is a brilliant question, comes from staff and procurement. They want to know what are the top 3 challenges or issues within NHS Lanarkshire or the health service as a whole that keep you awake at night. This is a question for everyone, but I'll come to Heather first.
Hi, Calvin. Thanks. You're right. That is a great question. It's actually a question I was asked at my interview. So I have prepared an answer previously for this one. And it hasn't really changed since my interview, although that was a few months ago now. The main priorities at the moment for the organisation are around recovering from COVID. We need to build on the great progress that we've seen in terms of the response to COVID across the whole system. We've done a lot of really good work with partners in health and social care as well as within the NHS, and there's a lot to build on there. So recovery from COVID has to be the first priority. As part of that, though, a second key priority is the well-being of our staff. Our staff have been absolutely fantastic during the whole COVID last 9 months, really, and have worked their socks off, but they're quite tired. So I'm keen to get them vaccinated as soon as possible, and I'm hopeful that that will be during December and January. And I guess the third thing for me is working to try and reduce inequalities across the whole of Lanarkshire with our partnerships, because part of the economic consequences of COVID will be an increase in the inequalities and the economic disparities across Lanarkshire, and I'll need to work very closely with colleagues to try and mitigate the impacts of these going forward. So I think that's 3. I hope that's 3, Calvin. Thanks.
Yeah, that sounds good. Jane or Eddie, do you want to add anything?
I'm happy to come in. I was struggling to restrict it to only 3 things that keep me awake at night, if I'm honest. I suppose I have to reflect, coming from a clinical background, the worry that I have about our staff managing peaks in activity. And it would be disingenuous of me to say that I can take that worry away from staff members. That's what, as clinicians and healthcare providers, we face all the time. There's peaks and troughs of activity, but I think because the past few months have seemed like nothing but peaks in activity, I really worry about that impact on an individual, stressing about have they got the capacity to deliver all the care that they need to the patients that they're facing. And sometimes that can just be for a few minutes, or it can be an hour, or it can be a whole shift. But it's intense and it's relentless, I think, at the moment. So I suppose all that people like Heather and Eddie and myself can really say about that is, please don't feel that you can't ask for help. You know, that there's no criticism at all in saying you need help with something. And there's no criticism either in feeling that you're being asked to do things out with your level of competency or with different levels of resources as well. So I think that's probably my biggest one. I think the other worry that I have is for our patients, and for those patients where we have had to make some difficult decisions about not being able to provide all the care that we would want for them at this point in time, and what that means to them. And I know that a lot of you have worked with us to make sure that we've applied the right priorities around about those levels of care. And we all understand that there's little or no harm involved for patients in those decisions. But for our individual patients, that's huge, because it's a life-changing event for them to have something that's been postponed. And I suppose my final worry that I would highlight is the long-term well-being, and I think Heather's alluded to that, because I think we have to acknowledge that the whole system of healthcare has changed and will continue to change. We're not in a settled position yet, but also our lives outside have changed as well, and people will have a lot of different worries about their family members and their own future careers and so many other changes that we need to be there for our staff and help them to manage that.
Thanks, Jane. Eddie?
Yeah, so, I mean, it'd be unsurprising that I echo both Heather and Jane. And one point I was probably going to focus on was that staff wellbeing piece. We're being asked time and time again to do things differently, to constantly expand our services, and people are feeling very, very thinly spread at the moment. And CMT have actively supported the development of the staff wellbeing service. Quite a big financial commitment to that carried out this year, and we'll look to see how we can expand that, particularly over this winter period. So I think Jane's point about, escalate to us, let us know we don't have a magic bullet, but we will help in every way we possibly can.
Yeah, thanks everyone for those answers, really good answers, and I think some big scary issues in there, but hopefully people are reassured by the thought and consideration that's been given at a senior level. So moving on to the next question, this comes in acknowledgement of the realistic medicine origins of this podcast from staff involved in delivering realistic medicine. How do you think we can apply principles of realistic medicine in addressing the backlog of planned care in Lanarkshire acute services? And I'll come to yourself, Jane.
Thanks, Calvin. So we've already been doing a bit of that. We spoke about patients having their care reprioritised. Those are patients who are on our waiting lists, and the clinicians who own those waiting lists have gone through every single case and scrutinised what they already know about the patient. So not just the referral form, but all the information that they know, to do that active re-vetting of the urgency of a patient's need to be seen, either face-to-face or a virtual consultation or whatever. And they've applied realistic medicine principles in doing that. And when they've had conversations with patients, again, it's been with the realistic medicine principles at their side, asking the 5 questions about what are the risks for me, what happens if I don't have this procedure, because I think we need to acknowledge that the risk balance has changed for patients coming into a COVID environment in the hospital, but also the personal risk to them, depending on the nature of the procedure, a procedure itself might carry an increased risk. So it's right and proper that we have those conversations. I think we need to do more, and we need to continue to get that message out into our communities, so that they understand that and don't feel that they're being disadvantaged by having those types of conversations. I think also that scrutiny over the waiting list, or the patients who are waiting, has helped us to understand where there might be some variation in practice. And because our resources are much more restricted now by the space that's available and the amount of time that it takes to do all the donning and doffing of different levels of PPE, we're very conscious of making sure that we maximise those resources, and therefore streamlining and getting a consistent approach to how we do things, I think, has come much more to the fore. And also, we had earlier this year, we had released a new consent policy, and that aligns very closely to realistic medicine, and that helped us to make sure that any patients who were coming in for procedures during the first wave and now subsequent increases in the incidence of COVID have a well-informed consent process that they can go through. And I think that's all thanks to our investment so far in realistic medicine.
Great. No, thanks, Jane. Is there anything, Eddie or Heather, you'd like to come in on realistic medicine?
No, I mean, I think that was a very comprehensive response and absolutely cuts to the heart of what we're trying to do at the moment.
Great. Thanks, Eddie. So next one's a question, I think, for yourself, Eddie. This one comes from the Brain Injury Services, but I think it's probably an issue that a lot of staff are being faced with, and they're looking for guidance for staff who work in a community team, but whose caseload spans both community cases and inpatient hospital cases. So how do they manage at this time working between a hospital site and then having to go into a patient's home and vice versa?
Thanks, Calvin. To be honest, there isn't one straightforward answer to that. I think keeping at the heart of this is doing the piece that only you can do. So if you do have mainly a community background and that's the main body of your patient group, yes, absolutely, carry out that care there and be prepared to carry out the care in the hospital, but as minimal a footfall as possible and being very, very strict on the use of PPE. But I do come back to that point of if there's general care, if there's something that someone else can do who's within the hospital, I would always support that being the priority. But if only you can do it, then being very careful in that application and probably linking with infection control if you're not sure. I think that's always got to be a default setting for this.
Great. Thanks for that advice, Eddie. Next question, this has come from occupational therapy staff, but it's also been asked by neonatal staff as well. And it relates to testing and routine testing for COVID of staff. I think some staff are aware that this happens here and there and in other boards. They want to know, are there plans to routinely test staff in NHS Lanarkshire for COVID-19? Jane, I think you might be able to answer this one.
I'll do my best. Thanks, Calvin. So yes is the answer. There are plans to extend staff testing. I'm a big fan, actually, of staff testing where we can do that and actually testing patients alongside staff groups as well, because I think the more we can understand about the transmission of virus in healthcare settings, the better able we are to control and minimise its spread, because we have unfortunately seen some spread between staff and patients and vice versa. So none of us want that to happen. So we need to understand that. The Scottish Government required us to do some very high risk areas as mandatory testing in those areas, not mandatory for the individual staff members, but that we offered it to those staff groups. And that's been well received and quite successful. There is an intention to roll that out to all staff, all health and social care workers in the future. That will probably not start until early next year, and it will be determined by our capacity to be able to support that, not just with the tests themselves, but with an IT system that records that so that it's meaningful and we're not just ticking a box, that we're testing people and recording useful information and able to respond to it as well. So it will need to be carefully thought through, and it will need to be done against a prioritised list of all the other tests that we have to do. But we've got a quite robust clinical prioritisation for applying any limitation that we have in test availability. So we'll use that if we have to, but there's lots of new tests coming online that we hope will restrict the need to prioritise, that we'll actually be able to do that as widely as we need to.
I suppose, Jane, the other thing to play into it is the vaccination programme. So as more of our staff are vaccinated, the requirement for this hopefully will lessen.
Yeah.
Absolutely. No, really good point.
Key point.
Thanks for that answer. Next question comes from physiotherapy staff, though again I think it's probably an issue that's facing other staff groups as well. So I'll pose this one to Eddie first of all, and it's about where staff have the capability and resources to work from home, and that's obviously been shown to work for a number of bits of the organisation. Some teams have got that capability, yet staff still need to come into the office. So it's really to get an idea of what the requirements for staff to come into the office and or versus the ability of staff to work from home?
Thanks, Calvin. Again, not an immediately straightforward answer. We would always support staff working from home. There was actually a question that the corporate management team struggled for its own application. So there will always be a balance of having a physical presence and not exclusively working from home. And again, I use CMT as a very good example. We would work from home 1, very occasionally 2 days from that leadership piece. So usually the decision on how frequently someone could work from home is best based on a conversation with the senior managers and leaders involved and the team themselves to try and find is balanced, a blended view to that. So there are no specific guidelines that we put out because it's probably something that doesn't lend itself well to that, but we support the decision making of our teams on what works best for them. Clearly, if an individual risk, they should be risk assessed and supported to work from home. But again, we would work with SALIS and our infection control colleagues, plus the line managers within the system.
Great. No, thanks for that answer, Eddie. Anybody want to add anything on that one? Okay, on to the next question. We've got a few questions in from neonatal staff, and emphasising really when asking the question that all staff appreciate the need for safety and protection and wearing of PPE. But obviously it's very difficult for staff who are wearing that continuously for up to 12.5 hours and only being able to remove it to eat or drink. So there's a question there, to what extent can this be relaxed for breaks and at other times? Is that a question for yourself, Eddie?
I'm happy to take it, but I'm sure others will want to come in. So one of the things we've found across the country is that actual staff working together at breaks can be quite a significant challenge because we've seen outbreaks based on that. I realise the comfort issue. I absolutely get that. So again, moving out of PPE, going on breaks, but maintaining appropriate social distancing, the use of kind of standard masks, hand washing, all the things we would expect within our environments would be a minimum and would be supported within the organisation. It's probably the right thing to do because of that level of discomfort. But if we can stick to that social distancing, use of masks, hand washing, and applying professional judgment depending on the nature of the room you're in, for example.
Could I add to that, Calvin, if it's okay? Because I think that it is a horrible environment to work in, really stressful at the best of times, but to have to wear full PPE is just really not very pleasant. But they're very much multi-professional environments. So I would encourage that multi-professional team to work together to see how can they cross-cover each other and work as flexibly as they can, pick up each other's duties, just, for a short part of a shift so that everybody can get a break, even if it's just to go out and up and down the corridor, get a wee bit of space and not be in PPE. So I think those things would be supported and we'd be happy to get HR colleagues to go in and help work through what that might look like. Eddie and I am sure would support it from a professional governance perspective because that's how we used to work together too many years ago.
Indeed, Dr. Burns.
Well, thank you for that. So again, from neonatal staff, and I think this is a really massive challenge that obviously staff delivering care in the front line must be facing, but they're following government guidance on visiting, but there's obviously challenging situations, specifically within neonatals where you've got sick children or babies who are receiving reorientation of care. It's a life-defining time, and as healthcare providers, the staff there are finding it difficult due to the impact on mental health and bereavement care for these patients. So I suppose it's just any words of advice or thoughts for staff that are facing that challenge.
So if I could come in with that one, Calvin, if that's okay. So there is ever-changing national guidance on things like this. At the heart of it, though, and I've said this in a few areas, is about a professional judgment. So we want to minimise footfall, we want to minimise that cross-contamination, but at the same time, if having a family member there will add to that person's experience to keep them psychologically safe, to do something by exception, we would support that. Again, trying to keep that to a minimum, but at various points, a decision will need to be made by a professional about relaxing some of the rules. Jane and I, again, have discussed this at length, and we will support someone making that level of decision, even if it varies slightly from what standard processes look like. And I've had this conversation with Cheryl as head of midwifery on allowing her that level of freedom to support our staff to make that decision.
Great. No, that's really helpful. We've got one more question. So this one's for yourself, Heather, and it comes from mental health and learning disability occupational therapy staff. They're asking which safe digital platform we'll be using here in NHS Lanarkshire for delivering with clinical groups. So really kind of any advice or information you've got about evolving digital platforms for staff.
So I'll probably bring Eddie in as well around this, but certainly during the pandemic, there's been a lot of work done around remote consultations, as you know, and I think before, like if you cast your mind back to kind of February of this year, the number of consults we were doing clinically was in the 10s and 20s that were being recorded anyway. There were probably more than that around phone calls, but certainly virtual use of things like Near Me was minimal. We're doing a couple of thousand of these consults a week now, so we have absolutely upped our use of digital technology. There are some challenges around group working though, using that remote technology, and I'm not sure that we've quite got a solution to that yet, which I suspect is what's behind this particular question, but I'll maybe bring in Eddie because he may be more up to date with where we're at with that.
Yeah. So that group work piece is being worked through, particularly on how we can do that. As a base though, for those teams, we are expanding the use of Morse, and that will be the baseline electronic system. Now that's been implemented in phases. We're just about to start phase 2. It's been an incredibly successful launch. I worked in Dumfries and Galloway when they did this, and this is a much smoother implementation. Everyone has really found it incredibly beneficial, and all of the project teams will come on over the next 6 months. I realise CAMS mental health are slightly behind, and will probably be towards kind of March, April, but to give them that kind of support that it is coming and it has been universally successful in implementation.
Great, no, thank you very much, Eddie. That was our last question, so thank you to all the staff who posed those questions, and thank you to Heather, Eddie and Jane for answering them so fully. We hope that you enjoyed this podcast and you found it helpful. If there's any ways you think we can improve it, or if you would like to see it repeated, or if you've got any questions you would like to see answered in a future podcast, then you can email myself at calvin.brown@lanarkshire.scot.nhs.uk and let me know. Thank you very much, everyone. Bye.
Bye.
Thank you. Thank you. Bye now.